essential functional impairment in activities of daily living, such as dressing, shopping, managing finances, etc. Over time, the criteria for ANI has been looked at and revised recently through the Alzheimer's Association in conjunction with the National Institute on Aging, and basically very similar criteria, with the exception of now one or more cognitive domains can be considered ANI, and also a self-reported concern by the individual that there's a change in cognitive impairment. But overall, the ANI classification really has to do with whether or not there are functional impairments. And as we know, with the introduction of antiretroviral therapy and how sophisticated it actually has become over the years, the rates of cognitive impairment in terms of people who are cognitively normal is actually is higher. So now people are living with very mild cognitive impairments, if you will, but we see this in about half of the HIV positive population. And this is from the charter studies that really looked at sort of stability of ANI over time. And this is looking at both suppressed versus all individuals who are part of the charter cohort. And you can see that the ANI group that's in the red, and then you have the NCN group, which is neurocognitively normal. You can see that in terms of activities of daily living, despite showing initially at baseline no functional impairments, over the time there seems to be a slight decline in the ANI group, suggesting that perhaps ANI is something that we need to be mindful of in terms of tracking over time. Now, when we think about sort of the criteria for ANI, it's heavily based, as I said, on one's functional abilities. So in the way that we assess it, some people simply ask, people to rate their ability to function in a number of areas, such as shopping, cooking, driving, managing finances, etc. And there's also performance-based, where you actually test them in the setting and you actually give them simulations of functional ability activities to see how they do. So one of the issues that at least we started to recognize, I think, as a field, is that sometimes self-report could be influenced by a couple of factors, right? So if somebody is depressed, we know that they tend to see things a little bit more negatively or might be more sensitive to changes that would be normal changes, but because of the negative bias in thinking, they may actually perceive that as a functional disability. So we wanted to look at people who may over-report their functional limitations, say as someone who is, meets criteria for depression, or people who may underreport or lack awareness because of their cognitive status. And so in this particular study, this was in collaboration with investigators at UCS. I did not mean to do that. Okay. In collaborations with investigators at UCSD, we looked to see how they performed on these various instrumental activity daily living assessments, so actual performance-based assessments in the lab, and we also asked them to self-report the degree of their functional disability. So as you could see, the graph on the left shows based upon, we had a cutoff, so anybody who was performing sort of within a standard deviation of normal performance on these functional measures, but they had reported significant functional disability, we sort of classified them as over-reporters. Under-reporters did the opposite. They said that they were basically functioning fine, but at least on our performance-based measures, they were greater than a standard deviation below the average for that sample. And then we had people that we called accurate reporters. So those were people who said, I'm having problems, and therefore they showed problems on the performance-based measures, or they said that they didn't have problems, and indeed they didn't have problems when we tested them. So as you can see, that people who had higher BDI scores, and to be quite honest, the BDI range that you see here was not very high. It's more, whoa. I'm sorry, I didn't know that it was that bad of a presentation. Yeah.
It's a new building.
Oh, okay.
At exactly the same time as yesterday.
Oh, really?
Yep. System warming.
Oh, okay.
I have to wait. Again.
So just for our online participants, we just have a little technical glitch here with the presentation screen. So Dr. Thames will return in a moment. There we go. We're good to go.
All right, thank you. Okay, so as you can see on the left, I was just saying that with the BDI score, it's really in the more mild to moderate range for those who, across these groups. But you can see that for those who had slightly higher BDI scores, they tended to be classified as the over-reporters in respect to functional abilities. On the right, you can see this is a global neuropsychological T-score based upon their performance, sort of a summary score of across various cognitive tests. And for those who tended to underreport, not surprisingly, they had lower cognitive performance. So this is just to kind of show that we have to be careful in terms of thinking of factors that might influence or bias self-report. Here's another study by Nicholas and colleagues that looks at sort of the stability of functional assessment geographically. Now, I thought this was interesting because it's looking at the correlation between cognitive impairment, if you will, and sort of abilities to function in these various activities of daily living. Now, I know this is a busy graph, but the lighter purple shows areas that were, or stability assessments that were weakly correlated with cognitive functioning, and this is looking across, various regions: United States, England, South Africa, India, Mexico. Now, if you see gray bars, it's just because that was not assessed in that particular region. But I thought this was interesting because the stronger associations between cognition and instrumental activities of daily living in terms of how it's assessed tends to be stronger in the United States, meaning probably that there's just been more work in this area, perhaps with the inclusion of performance-based assessments. So it's just something to think about, that there's some variability in terms of IADLs and cognition across and depending on where you're assessing. Now I'd like to talk a little bit about aging with HIV. We know that over half of the HIV population are ages 50 and older. That's been demonstrated through lots of CDC statistics, et cetera. And this is important because historically we know that there are similarities between aging, what we call typical aging processes, as well as people who are younger who have been diagnosed with HIV. So this is sort of a study highlighting some of the very similarities in terms of phenotypes. I won't go into all this because I know that this has been discussed quite extensively throughout the conference. But we do know that there are some similarities. So the question really is, what happens as people age living with HIV? So one of the questions we had was about looking at brain, whether or not there was a augmented aging or accelerated aging process in brain white matter. And this is because older studies had suggested that there was a gap between one's chronological age and their estimated brain age. The gap was actually quite larger in earlier studies because a lot of those studies included people who had various levels of viral suppression. So some people still had very high viral load. This was sort of, including cohorts who had been around early on in the course of the disease. And so we wanted to sort of see what would we find if we were to look at this aging process in brain white matter. So we were able to collaborate with the Cambridge Center for Aging Neuroscience and the University of Oslo. And what they had done is they had acquired, using diffusion tensor imaging, which is just a neuroimaging technique to look at the integrity of white matter. They had collected sort of this diffusion tensor imaging data across people from ages 20 all the way through 90. And these were people who were presumably healthy, free of any chronic conditions. And we wanted to use that data to sort of see if we could estimate one's brain age based upon this other data. We wanted to look at it within our cohort of both people with and without HIV infection. So what we did was we used the machine learning approach, which is you're just training. It's basically just coming up with a regression algorithm based upon data that you have, where you say, okay, these are cognitively normal people with various healthy brains, and now we want to see what the metrics are for this white matter integrity and apply it to our cohort. What we found was interesting in that you can see in people living with HIV that for the most part, their chronological age and their estimated brain age based upon the deep diffusion tensor imaging data was pretty similar up until they hit about the age of 50. You start to see more of a dispersion between those who are living with HIV and those without. So we found about a 5 to 7 year gap between one's chronological age and their estimated brain aging based upon a DTI estimate. We did not see this gap in the HIV negative control group. So as we're thinking about sort of how do we think about cognitive impairment and HIV infection, there has been some recommendations. The Nightingale group has suggested that really in order to look at HIV-associated brain injury, you cannot just use cognitive assessments or self-report of functional activities. You need to look at other factors such as whether or not there are comorbid medical conditions and using some type of biological metric, whether that's imaging or looking at other biomarkers, and being able to then classify whether or not this is true HIV-associated brain injury, and that's separating it out from any other chronic condition, which can be quite difficult to do, and then whether or not there is suppression of viral load. And so then, the chart sort of splits off. Is this legacy, meaning that was this brain injury associated from early on, whether it's low CD4 counts or whether it's being on certain antiretrovirals that were neurotoxic, et cetera, or is this something that's active and ongoing? And with this model, I came across this paper by Dr. Lucette Sisik, who I thought it was quite interesting in terms of using an approach of looking at cognitive profiles of those who have various classifications of hand. So looking at whether or not there were HIV positive individuals who are stable, intact, meaning from baseline to follow-up, they demonstrated normal cognition versus those who had a stable hand, meaning that they had cognitive impairment and some cognitive impairment, but that remained stable, versus those who progressed and declined. So in this graph, essentially, it's looking at these groups and using neuroimaging magnetic resonance spectroscopy that is looking at these neurometabolites in certain regions, particularly in the frontal white matter areas and the corpus callosum. And what's interesting here is even for those who have stable, intact cognition, they're still slightly lower than the neurocognitive controls, suggesting that this could be a way to look at this information. I just want to briefly highlight, and I know I'm out of time, that that looking at ANI in other populations is something that people are doing, looking at vascular injury. There's been a group in the Alzheimer's disease space that has found that looking at white matter integrity might be an extreme expression of sort of general injury that's in the vascular watershed regions within cerebral white matter. So these are people who are cognitively normal, but they're still demonstrating these neuroimaging abnormalities. And then finally, I encourage you all to look at this paper. I thought it was really a nice review of various mechanisms that can underlie HIV-associated cognitive impairment and emerging therapies. And finally, I'll just say thank you because I know my time is up.
Thank you very much, Dr. Thames. We'll move right on to Dr. Moore. Dr. Moore is a professor of psychiatry at UCSD, an investigator at the HIV Neurobehavioral Research Program, and a licensed clinical psychologist with specialized training in neuropsychology. In the interest of time, I will not complete reading all of his accolades, but will rather say that he and Dr. Winston are going to speak to screening for ANI as being beneficial either in support of it or not in support of it. So Dr. Moore is going to speak in support of screening for ANI. So Dr. Moore.
Great, thank you very much. Alan and I decided to leave our boxing gloves at home and just go with a verbal spar here. So I have no disclosures other than I receive NIH funding. So I thought it was nice when Brian Pence gave his talk the other day to kind of have up front what are my take-home messages, and then I'll go through and unpack those one by one. So, the premise of my pro argument is that rigorous, objective diagnostic criteria are helpful in the context of people with HIV. ANI does predict subsequent transitions to MND and relates to neurobiology. We can see that through neuroimaging studies. There's always going to be a balance between sensitivity, identifying someone who has impairment, and specificity, identifying those who don't. So there's always going to be a balance. And not to bore you with psychometrics, but that's an important part of this story. And there's going to be difficulty in identifying mild cognitive impairments. That's really not unique, as April just showed, to people with HIV. And detecting mild cognitive problems and subtle problems is always going to be somewhat of a challenge regardless. And lastly, that identifying neurocognitive problems through these objective methods among people with HIV early is important for brain health, and that as new treatments come along, we'll want to know who does and does not have these mild impairments. So number one, rigorous objective diagnostic criteria are helpful. April's already mentioned this, but the Antinori criteria from 2007 does have objective neurocognitive neuropsychological testing as a key component of it. And I think we can point to earlier in the workshop where we did not have good definitions of frailty and sarcopenia and the difficulties in those fields where there is not a consistent definition. And here we've had this definition and worked with it for some time. And I think certainly there's room for discussions about how that may be updated, but using and starting with this nosology, I think is a great place to start. As April also pointed out, the real key difference between MND and ANI here is this functional impairment. Both groups have mild neurocognitive problems, but the ANI group does not have any functional impairment or doesn't report or is not seen, whereas the MND folks do. So in terms of the cognitive aspects, they're very similar. But the ANI do not show those functional problems. And I think it's important to point out that the Antinori criteria do have supplemental materials that tell us how to handle co-occurring conditions. So those are outlined. I think part of the challenge is there's in a supplementary document and people miss them, or it's hard to apply them because people have to painstakingly go through those other co-occurring conditions. But it's important to know that that guidance is there in the Antinori criteria. And these are just to point out that really you have to have HIV-associated cognitive impairment in Frascati. So, and that there are these different levels of comorbid conditions. And, if you wanted to be most rigorous, you could just say, I'm only taking people with minimal comorbidities and applying those criteria, and you could look at it in that way. My second premise is that ANI predicts subsequent transition to MND and relates to neuroimaging. In the interest of time, I'm not going to really show the data as much as just tell. But here, April showed from the same study, but this one is predicting percent survival here in the transition on the y-axis. On the x-axis, we have time, and you can see that that being neuropsychologically normal is more associated with longer survival, whereas ANI is a risk for moving to symptomatic status. So this is percent survival to transitioning to MND. Scott showed some of these data earlier, but just to say that in the Charter 12-year follow-up study, we do see evidence of abnormal decline in about 24% of individuals. As has been brought up previously in this conference too, that 70% of those people remain stable and 6% improved. So it's not to say that everyone's going to have cognitive impairment, but that we do want to detect the people that have it. This study, I'm not going to go into the details, but it used a more stringent criteria for impairment, so using negative 1.5 standard deviations instead of 1. And when we compared this, the Frascati criteria actually mapped more strongly onto the neuroimaging data than when you applied a more stringent criteria where you'd miss some of the people who actually had objective impairment on neuroimaging. There'll always be a balance between sensitivity and specificity. So in this graph here, in the top one, we have a cut score, a t-score of 40, which is 1 standard deviation below the mean. And at that cut score, you get a pretty good balance between sensitivity and specificity. Some have argued that that might over-detect cognitive impairment. I'm trying to get my pointer to work, but if you move on the bottom graph to a t-score of 30, you notice that you're going to miss a lot of people who actually are neurocognitively impaired. And I would argue that I'd rather identify people who might have impairments, try and unpack the etiology of those impairments, and move forward from there, rather than to not use objective testing to identify those impairments. My fourth premise is that the difficulty of identifying mild cognitive impairment is not really unique to people with HIV. Subtle impairments are difficult to detect, and this is a phenomenon that is found in many different contexts. And so this type of discussion that we're having here is happening in many different fields. So recently there was an article in JAMA Neurology looking at a new framework for dementia nomenclature. So these types of discussions are ongoing in different contexts, and they'll continue to go on, is my suspicion. And then also, I think we need to consider how we can use the existing framework and potentially build upon that. So there are initiatives to look at biotypes. There are initiatives to look at phenotypes within and building upon the existing criteria, rather than kind of throwing the baby out with the bathwater. And lastly, I'll say that identifying neurocognitive problems among people with HIV early is important for brain health, and for us to identify potential treatments to prevent either further decline or maintain stability. And I think in many health conditions, we can agree that early detection leads to better outcomes. And I would argue that in things like heart disease, cancer, cerebrovascular disease, depression, and in Alzheimer's disease, that early detection is key, and that treatments for Alzheimer's disease, it is not the same as hand, but they're continually being challenged by finding people too late in the process to be able to change something. So we want to identify people early and make interventions. We certainly have some new interventions that are coming that are not just related to amyloid and amyloid interventions. And relying exclusively on clinical judgment or patient self-report are likely to miss people who are at the earliest stages. So with that, I'll close and acknowledge my collaborators who've provided some slides and contributed to this, as well as some of our key research staff. Importantly, the study participants who give their time, patience, and energy to our studies, the HNRP group, and NIH for support. Thank you.
So it's a pleasure to introduce Dr. Alan Winston. He qualified from Glasgow University and is professor of HIV and genitourinary medicine at Imperial College London and a consultant physician at St. Mary's Hospital. I'll deviate from the script a little bit to just say that how much I admire Alan, and that's based on his substantial intellect and his accomplishments, but also that he dared to disagree with me on certain things. And while I didn't appreciate that earlier in my career, Alan taught me how important it is to have debate and have discussion about different viewpoints and ideas, because none of us has all the right ideas, right? And Alan taught me that if we have discussion and debate, the truth will out. And ultimately, that's what we all care about, right, is finding the truth. So thank you, Alan, for that, and welcome. And Alan will talk against the proposition on screening for ANI.
Okay, thank you very much, Scott. Good morning, everybody. So I think when Scott asked me to do this debate, he knew he couldn't ask me to do the other side. It wasn't a toss the coin, okay? Which makes it a bit easier, actually, because I am debating what I fundamentally believe in. Now, I could stand here for hours and hours and hours talking against ANI, but I have 10 minutes. So I have what I think are the 6 most salient points. Some of the points have been brought up already, so I'll go through them quite quickly. Some of the points haven't been brought up yet, and I'll spend a bit of time in this. So firstly, with the hand criteria and ANI, there's mathematical flaws from the start. Now, we have heard about this. It's all based on cognitive testing. If we have a standard curve for a normal distribution, 16% of the population are going to be more than one standard deviation out of the mean. Not all of them will be cognitively impaired. And when you put a whole load of tests together, you end up with high false positive rates. Now, these are cognitive results from the POPPY study, which is a UK and Ireland HIV and ageing study. And we have people with HIV on the right and people without HIV on the left. And you see that the global T-score difference is 2, 50.6 versus 48.5. So not much of a difference. What we do see is in the people with HIV, there are some outliers at the bottom. And this is probably the legacy effect for the individuals that do actually have either legacy damage or active brain damage. But for the majority of people living with HIV, their cognitive performance is very similar to those who don't have HIV. Now, some of you will be thinking, oh, this is just a crazy UK researcher. Well, actually, large US cohorts have come to the same conclusions, that the effect size and differences in cognitive performance between people with and without HIV is minimal. When we take our POPPY data set and then put it into categorical criteria, we see the same results as everybody else, that 30% of people would meet the Frascati, the hand criteria. What's interesting is 16% of people without HIV who can't possibly have HIV-associated cognitive impairment also meet these criteria. You can see the different criteria here. Sam Nightingale in Cape Town has done a great job of taking a single data set, so one test of cognitive testing in a cohort, and putting lots of different criteria, lots of different cognitive criteria. And you can see that you can categorize this cohort as having 20% up to 97% as having a cognitive disorder, depending on what criteria you use. So all of these criteria have flaws. So there's mathematical issues. Longitudinal trajectories. So we've heard that people with ANI go on to develop symptomatic cognitive impairment. Now, there's been several quite large studies looking at trajectories. Scott, I've chosen yours. This is the Charter study. What we see in all these studies are that the people at baseline with ANI are different from people without ANI. The comorbidities are higher. No wonder they progress. What I would say to you is check somebody's blood pressure, because it's much easier than doing formal cognitive testing. And yes, you'll see neuroimaging differences, because people with vascular dementia and hypertension are going to look different on brain scannings. The Swiss HIV cohort have done some lovely cognitive work in recent years, and they've looked at longitudinal trajectories. We've heard at this meeting that cognitive performance improves over time, and you can see here on the panel C the red and then it going out to the blue. And if you look at panel A, which is the categorical changes, it's just a mess. People are going from one category to another, so it's not really very coherent data. And also, we've looked at longitudinal trajectories, and although at baseline we see a slight difference between people living with HIV and people without HIV, the trajectory in virologically suppressed individuals is identical, which is very reassuring. So what does this all mean to research? Well, this is an old slide that needs updated, but every interventional study in the field has been futile, and if I had updated this, we just have more futile studies. Now, I want to give an example. There are treatments for Alzheimer's disease, and that is based on people with Alzheimer's disease getting an intervention that works. If we take people with AIN who don't have anything wrong with them, give them an intervention, then no wonder this is all futile. So it's the null hypothesis. We need to be taking people with HIV-associated cognitive disorders in order to test our future interventions. What about clinical guidelines? Well, thankfully, to my knowledge, every large international guideline does not include these criteria. The updated EACTS guidelines were released last week, used the HABI criteria, but there's no mention of ANI. Now, this is what I really want to home in on, work and social implications. And this aspect, it actually breaks my heart that this is happening, and I think we all really need to think about this. Now, this is a positive example, but they're not all positive examples. So prior to COVID, the UK Civil Aviation Authority, which regulates pilots in the UK, were looking into restricted licenses, and basically, we're talking about ageing at this meeting. Pilots are ageing as well. And the standard pilot license in the UK is unrestricted, where you go through medicals every couple of years or something, or a restricted license. And a restricted license is where you have a medical condition and you have to go through more screening to maintain your license. But the problem the UK Civil Aviation Authority had was so many pilots had restricted licenses, and you can't have two restricted pilots flying a plane. Planes weren't taking off. So they wanted to look at medical problems to see if the restrictions were really necessary. So they came to BIVA, British HIV Association. They did a lot of work with us. And we said to them, why have UK pilots got restricted licenses? And they went, well, it's because of HAND and ANI, because we can't have people developing cognitive disorders, so we need to screen them and put them on restricted licenses. So we spent a lot of time sharing our data from POPI and COBRA, the Swiss HIV cohort, other cohorts. And this is an independent regulator. So they independently looked at the data and came up with the conclusion that it was all a load of nonsense. And thankfully, UK pilots meeting certain criteria living with HIV now have an unrestricted license. We've seen studies like this coming from South Africa that should drivers, lorry drivers with HIV be allowed to drive because of cognitive disorders. There's life insurance issues. There's loads of challenges facing people with HIV, and all we're doing is making this worse. Now, as clinicians, as clinical researchers, as scientists, as well as being good clinicians and conducting good research, we also have to be the advocates for people with HIV, and I don't think this is advocacy work the way it currently is. Lastly, what about the basic principles of medicine? So I want to go back 2,500 years. So primum non nocere. Can we all convince ourselves that we are doing more good than harm? I think you know my view, and I'll let you make up your view. So in summary, the arguments against ANI. There's mathematical flaws from the start. 40% of people with HIV do not have cognitive disorders, and we've got to stop saying this. Longitudinal trajectories, there's no difference when we look in virologically suppressed cohorts. Research is being rendered futile. Clinical guidelines, thankfully, are being sensible. There's major work and social implications, and it's limiting what people with HIV can achieve in life, and it's not adhering to the basic principles of medicine. I have 48 seconds left. Thank you all.
For our final speaker, I'm happy to introduce Andy Cates, who's also from San Diego. He's a community advocate. He began volunteering at Christie's Place, an agency serving women, children, and families affected by HIV/AIDS in San Diego. His past and current work has included treatment and research education, supporting group facilitation and patient advocacy. For nearly 20 years, Andy has been an active member and currently co-chairs the Community Advisory Board at UC San Diego's Antiviral Research Center, where I also work, and is a member of the AIDS Clinical Trials Group Community Science Subcommittee. So Andy's going to provide a community perspective, and thank you for being here.
Thank you for the invitation. I really appreciate it from the bottom of my heart. This is the first time I've been to this meeting. I kind of wanted to get here for the last 10 years, but I guess I wasn't old enough yet. So after the last two talks, I think half of my slides are useless, and you know, I don't know where I'm going to land on this with the debate, but any of you that are experienced in neuropsych testing, please get your papers out and your pens and all that stuff, and tell me at the end of my talk how much ANI or MND I've got. So we do know that community is aging. That's why we're all here. I'm not going to go over the statistics because you already know them. But what I'm going to talk about today is a little bit of background, which I will speed through because a lot of that's been talked about before. The pros and cons of ANI from a community standpoint, community priorities for the HIV and aging fields, and then a few simple steps that may help down the road. So with the background, you know, in the early days, people were dying. People were sick. Some of us survived. Some of us were lucky enough to do so. But we watched our friends and family deteriorate, and it was really horrific. Luckily, some toxic medications came out. That was great, and killed more of us. Some of us took those medications and lived in monotherapy in high doses, which was all we had at the time. And then when combination ART came out, as you all know, people all of a sudden had a life. And they had diarrhea as well, but now that's largely been taken care of by much better medications, and thank you to those of you that are developing those medications and did develop them. So anyway, I know a lot of you have made your careers in this field, and I want to thank you for that because I know it's not a money-making situation. You know, you'd be in plastic surgery or orthopedics if you really wanted to do that. And your expertise in this field is really, really comprehensive, and it's valued by us by quite a bit. And I think together we've changed a lot, excuse me, in the medical field. It's really been wonderful to watch how it's affected different disciplines in the HIV world. So we also have several people that have been cured, and I would be remiss if I didn't point that out as far as the history is concerned. So they started out with people with HIV. Now they're people without HIV, which is great. So it's been great. We're living, but we could do better. So there is more work that we can all be doing. I won't really dwell on this because you've seen this probably for half of your lives. And I will just say that HIV, once it meets you, it decides it likes you and it wants to take up a homestead in your body, in your brain. So that happens really early on, even on art with a suppressed viral load. You know, it's still there. So I guess you can probably think about with the last two talks where I land on the pros and cons of this. There are a lot of cons. You know, being aware of what's going on up here certainly can have a lot of implications. It can have insurance implications, as we've heard. It can have stigmatizing implications, things that we do to ourselves. It can make brain fart the first word coming out of your mind all the time. See, there's one for the neuropsych testers. But it doesn't help us any to, you know, continue to worry about these things and the stigma, but it is not going away. So we kind of grapple internally with ourselves, and we wonder what our self-worth is, if we're valuable to our friends, our circles that we've had for years, and a lot of times that'll make us withdraw, turn to isolation, and become very lonely. We're also concerned with, gosh, you know, this ANI thing. What if the driver's, whatever it is in your world, driver's authority, for us in California, it's the DMV. We love them. And, you know, will I lose my license? Will my doctor remove my license from me? You know, that's something that we really are, you know, especially in Southern California as a car culture, we're really, really not, you know, ready to warm up to that. So that's a danger. We also worry about growing into more decline to where we can't take care of ourselves. And maybe personal safety even comes into play there, you know, not being safe in the kitchen, going up and cleaning your gutters on a ladder that many of us shouldn't be doing. And then there is stigma again. That's the one that really won't go away. We get stigmatized internally, externally. We read the newspapers, any news feeds, we hear political things, we get stigmatized. Stigma just doesn't go away. However, there are some pros. So the first pro is the same as the first con. You've got to know that you've got something going on. While that may not be clinically, clinically visible, you know that it's happening. And then that creates more paranoia, and you know that that's happening even deeper. And then, you know, it's just, you know, all out the door at that point. Probably should have brought the water up here, but that's all right. Physical and brain exercise is definitely helpful. Things like crossword puzzles, thanks, Scott. Things like crossword puzzles, brain games, we all have a component of that in our phones, which is really helpful. I play Sudoku all the time. My aunt, she won't play Sudoku on a phone, she'll only do it on paper because that's her age showing through. My age, luckily, I get to use the technology. But diet is also a thing. We know that anti-inflammatory diets, Mediterranean diets, are much healthier for people. Inflammation being one of the key components of HIV and its effect in the CNS. So we should try and eat better. We should try and not have as many fried foods and processed meals, all that. So it does help to know about your propensity for maybe continuing down the road to decline cognitively and be able to take care of it with food. Exercise, that's huge. That can also attenuate some things. If you have the opportunity to have a support group or attend therapy sessions, that is hugely important as well. It's way, way helpful. I've been away from my therapist for probably 3-4 months now, and I noticed change just in that, in my cognition. I mean, it helps to get things off your chest and you know, go on about your life. So there are some interventions, and there will probably be more coming down the road, but they don't necessarily have to be in a pill form or even a long-acting shot, or short-acting for that matter. Okay, so please screen us for ANI. It's something that will help us throughout our lives. It will also help you watching us in your in your quest to keep us healthy. So polypharmacy, that's another thing. You know, we've talked about, we hear about a lot. I personally take a handful of pills twice a day. You know, resistance is something that I live with because I've been on ARVs since 1991. And for 15 years, I was unable to suppress my viral load, largely because there weren't great combinations of therapy initially. Then I was taking a lot of supplements which interacted with the drugs, and you know, it's depressing when you think about it. And we wouldn't do these things today. We wouldn't give somebody charcoal tablets to prevent gas from tenofovir, but that happened to me. And you know, I'm thankful that we're where we're at, but we have to remember and not blame the old days, because that was state of the art back then. So our priorities that we have, I know you've heard a lot about these over the years, and these are certainly not comprehensive. It's just a smattering of things, if you will. But please just listen to us. You know, the people that are in this room anyway, and that run in these circles, are familiar with research. They're familiar with science. We're not, as an HIV community, we're not all the same. It's not a homogeneous population. Some of us have really, really glommed on to the science and the research that you do. And, you know, we're kind of sad that you guys put age limits on us all the time for your studies. For the clinicians in here, you know darn well when you see an 80-year-old patient come in, you're going to give them every vaccination under the sun. So why not test vaccinations on us at 80 years old? That is something that should happen, because that's what's going to end up on the streets and in the clinics, is older people getting whatever compounds you're testing. So study us with the same verve that you had when you were looking to keep us alive. You know, you're going to lose us as a cohort eventually. I'm not going to be here forever. My older colleagues, I'm 60, but my older colleagues, they're going to be here maybe even less than I will be. So you have a willing and experienced cohort right now to test, to study, to develop therapies, to develop different interventions. Please don't ignore us. And I know it's tough because of the funders and things of that nature, but that has to happen regardless. So social science, that's something we've started hearing a lot about. It needs to be baked into every protocol, but certainly in any HIV and aging protocol. So social scientists, here's to you. Thank you. Everything we do is a behavior, and you're the ones that study that. So we need to increase some aging services in the clinics as well as the AIDS service organizations. And if you can partner your clinics and your practices with AIDS service organizations, they have the capacity to do things like, you know, go to movies with people, or take walking tours, and do socializing activities, exercise, etc. Because that is very helpful, and getting out of the house is going to be good for all of us. So if you can include significant numbers of women, that might be a good thing to do. Significant numbers of people that are in marginalized or underrepresented populations, meh, why not? Just try throwing one or two in. We need this data. You need this data. Do it. When it comes to your proposals, for example, I'm going to skip ahead just a touch. remember when you're writing your grant proposals and you see these words like subject and infected, get rid of them. Write participant instead. Send that to the NIH. And so that might bring a few more people that don't trust us into the equation here. So that's, you know, my recommendation. Diversity is a huge thing. We have to have that. In this country, we have AARP, American Association or whatever of Retired Persons, and they're showing clearly on the slide that diversity is important to them. Well, that is a nice diverse group, but it doesn't really capture everybody. And I know you have patients that don't look like that. I know you have participants that don't look like that. There's people that are on the streets. There's people in other living circumstances. They need to be included as well. So that was a start as far as what their idea of diversity is. But if we really want to move the needle, this has to be something that'll fit everyone. So I see I'm running low on time. Voluntary wellness groups, that's something that I kind of hit on. People that can't get out of the house, help them out with the technology that's available to us. Thank you, COVID. You brought us further along than we thought we were going to be. People need transportation to get to their appointments. All of you need to go get new board certifications so you can treat older people. I know you have the time to do that. So if you don't have the time, maybe you need to point to those colleagues and say, hey, learn about HIV. So some simple steps that might help are available on the NIH's website, for example, regarding stigma. Language is something that is huge and it matters to all of us. Even if it doesn't matter to me personally as an advocate, I advocate for those that it does mean something to. So that is something that you can find in the NIH website is the link to destigmatizing language. And the reason it's important is because when we hear infected, that's what we think. We get withdrawn. It's just not a pretty sight. And there's another thing that we don't really care for, and it should come up. And that's the word subjects. Those folks right there, subjects. I'm not a subject. Don't call me that, please. These are also subjects. And with that, I'm going to kind of leave you with a thought. You've probably heard of the last gift study. All this ANI and hand and everything, that can be studied with live people, but also think about it with autopsies that are done in a rapid form with people that have live brain tissue. Maybe you can find the signal in there somewhere. UCSD is the place to go for that. Thank you.
So thank you to Andy and to all the speakers for their contributions. I'd like to open it for discussion, and with my apology to Professor Bourlet, I will take the speakers, so the coordinator's prerogative, and just ask one question for discussion first. And that is based on Alan's observation that people with ANI have more comorbidities, which include hypertension and depression and diabetes, and we screen for those in clinic. So what's the incremental value to that? And we have treatments for those. So what's the incremental value to that of doing any cognitive testing? And related to that, do we look for functional impairment in the clinic? Do we assess people's daily functioning? Because for me, that's an important additional element that understanding whether someone's cognitively impaired would allow us to address, to engage them further about whether their daily functioning can be supported better. And an issue related to that, Alan and I have discussed before, has to do with some differences in the American healthcare system and the UK healthcare system, but I've said enough. So, you know, what's the incremental value of doing cognitive screening in addition to screening for Comorbid is also a bad word, so to be avoided. So other medical conditions, screening for other medical conditions, and assessing daily functioning in our patients.
So Scott, I think it's a really important point. I don't see any incremental benefit. I think that the challenge we've got is the screening for other medical conditions isn't always being done, and we've got the evidence base to do that, and there are interventions. I don't see any benefit on top of that in people without symptoms, and whether it's overt cognitive symptoms or functional symptoms that you're alluding to, fair enough, but we need to get much better at just generally screening for comorbidities. We've always complained that there's no evidence specifically for managing comorbidities in people living with HIV. We now have evidence from 2 studies. Just about everyone with HIV is probably going to be offered a statin in the not too distant future, and we should be doing screening for anal cancer. How often is that happening? So we've now got evidence of interventions for comorbidities. They need to be implemented before we do whether it's further research, but just blanket cognitive screening is just going to waste time, and we need to be applying the evidence we have for long-term health management.
I think we should be screening for comorbidities. I totally agree with that. I think at least in some of our data, we've seen that, for instance, if you identify cognitive impairment and depression, that people are more likely to have daily functioning problems. So to me, that would argue for screening for cognitive impairment as well. But I agree with Alan that we should definitely be screening for comorbidities and treating those too. One minor point related to treatments for Alzheimer's disease work. Those treatment effect sizes are relatively small. And almost all Alzheimer's disease presentation is a mixed presentation too. There's a lot of vascular changes in people with Alzheimer's disease. So I think, to some extent we agree on a lot of things, that the comorbidities are contributing to what we see both for cognition and daily functioning. So I'll leave it at that.
April or Andy, anything to add?
I'm not sure if this is on. Okay. Great points. I would say that in some of the patients who I see in clinic, I think about we assess to see, do you have a certain other chronic medical condition, but I think looking at the history of which they've been adherent to medications, the course of it, whether it's uncontrolled hypertension versus controlled, I would encourage that we have to be more specific around those issues as well as we're looking into it.
Go ahead. I have a couple of thoughts. Knowledge is power, and I don't know that the screening needs to be as formal as a screening would be, say in a research environment. When we're talking about the clinic, I realize that there are time constraints that are very difficult to get around. So, one of the things that you could, potentially do is, I am blanking on who actually has this quote, but Eric Darr, for those of you that know, he always has in his signature line, listen to your patients. They're telling you the diagnosis. So if someone says, I think I'm really kind of slipping up here or something like that, if you notice that it's clinically relevant, significant, fine, deal with it. But if it's just something that, might be very casual, just why not handle it in a verbal way and just say, hey, you can maybe do some exercise and eat a little differently and blah, blah, blah. Or maybe I'll send you to a nutritionist or something. But there doesn't have to be a reason that will show up on someone's record, I don't think.
And if I can just add, Scott, I think that's really important, Andy. I'm not saying never screen for cognitive impairment. We have to be asking about it, and we need to be when subtle symptoms are coming across in a consultation, that needs to be looked into in a lot of detail. And we presented at CROI this year that when we actually investigate people, we're seeing 20% of individuals with CSF escape, where the virus has escaped. But that's in people with symptoms, and it's really important to identify the symptoms and not be missing that.
All right, well, now with my apology, going back to the floor, Professor Bourlet, number one.
Much I enjoy this format, and I hope that you're going to repeat something like that next year. So thanks, Alan, for disagreeing, and thanks, Scott, for opening up the discussion. Just a couple of points. So one issue with the hand classification that I have. So in our study, in addition to the BCAM, we did full neuropsychological testing on 263 people. And then we had to decide how are we going to turn this into a hand classification. And that's when I realized the extent to which people operationalize the Frascati classification in different ways. And when we applied the different operationalizations, we ended up with, in the same people, rates between 25% and 75%. So because we need to be pooling data to learn anything, I think that saying in a paper that, we apply the Frascati criteria really should not be considered acceptable. And people have to meticulously, obsessionally describe exactly what they did, for one thing. But the other reason why I sort of disagree with the statement that we want to catch this decline early and therefore we should screen for ANI, I think already by the time people get to ANI, you've missed the early phase, because the early phase was the decline within the normal range. So you're missing the most important phase. So, to do the hand classification, you have to do the neuropsychological testing, which is already not applicable to most settings. But then if you're going to do the neuropsychological testing, in addition to applying the cutoffs for the hand classification, you could turn your result into a true measure by applying, for example, rash analysis to your neuropsych data. There's no reason why you should do one thing or another. You could actually do both. And then you could catch the decline in the normal range, and you could have a trajectory so that you can include in trials people who are declining as opposed to people who are stable with legacy effect.
So if I can respond, I think having healthcare information is useful. And Andy's spoke about how people want to be screened and want to have medical screening, and none of us are against that. And what you're saying to me is information's good, just don't categorize people as having cognitive impairment. What you want is to know trajectories so you can see when people are changing, and I completely agree with that. The problem is, really within most healthcare settings outside of research studies, we're not going to have the resources to undertake this. In an ideal world, maybe, but there is a resource limitation. But I think the main point is not to categorize people and not to tell people they've got some sort of cognitive disorder, because it's giving the wrong message, and it's giving the wrong message not just to individuals but to society as a whole.
It's not, most settings consider that it's not ethical to screen people for a condition that you have no treatment for or no approach for. So if you're going to be screening for something, you should have in mind, what is it that I'm going to be doing with this result?
So we're over time. I want to give Dr. Clark a moment to question or comment, and with my apology to Dr. Green, and just ask that you speak with them afterward, because we're out of time. So
I'll make it brief then. I'm still really worried at how we tell patients or people living with HIV what brain health actually is, and how do we promote brain health, because I don't think we can do that. But if we're talking about as a neurotropic virus and all the other comorbidities and the things that people do that might have an impact on brain health, how do we tell people living with HIV to optimize their brain health? And I think that's a really important thing, because everybody should have that information, but specifically what is relevant to people living with HIV. And then the second thing that really interests me particularly is, how do we predict those few individuals who will develop specifically HIV-related neurocognitive disease? What are the missing factors that we don't know right now? Are there ways of testing, viral proteins in the brain, or some other diagnostic that we will be able to eventually hang something on, that we can say this individual might develop some neurocognitive impairment, and we can do something about it now before neurocognitive testing suggests that it's too late.
So with that, I'll bring the session to the end, and I just ask again that everyone complete their feedback and to stay here, because there is the next session on how do we make this happen, prevention complications. So welcome Dr. Green and Dr. Margolick to the stage to lead that session.
Yeah.